make sure that, I wasn't sure whether it was.
Yeah, you know, I think what we'll do is, by next week, we'll be the whole, then we'll,
Okay, that's why I wasn't sure, you normally have someone.
yeah, we normally have.
What? Yes. Okay. And.
Your, phone, got the door, please.
As always. It's Friday, 4-day, 5-day work. I really 4-day work. I thought we were working over here.
Yeah, running close. That number is that.
I turned bright red. Yeah, she's turning bright. Oh, yeah, the bathroom. Yeah, I think you should be back to you. Yeah. This is.
Yeah, audio.
Oh. Oh, you better, yeah, 'cause this is more of your style down here. You might get peanut gallery. Yeah. And then. Man, you have not sure. 2 doors down. Cube thing is. And he made some reference to being such a psychiatrist. Diaz, you all know Dr. Diaz. So if you don't know Dr. Diaz, I want to point it out. And this is all child here, but I said, oh, she's childish too. It's a good old lady, you know. Yeah. Yeah, you just be right in the deputy. Yeah.
I trained in undergraduate.
With me? Oh, they did. Were you on? Yeah. Oh, no, I don't. Really? Oh, that one. Yeah. Yeah. You were one of my junior members.
That was a good experience. It's really quite another school.
Tell us
Yeah.
all that.
The next week.
I had to finish you. Yeah. Judy left. I would say for 3 years. I don't like yours too. Are you serious? Oh, you're not gonna pay attention? It sounds like it. Yeah, I knew Mary Lamb before she started. Okay.
I always try.
That's fine. Jane. Yeah. What's the name? I am. So let me have it.
So now,
Okay, well, I think it's time for us to get started. We've had our academic 5 or 10 minutes together, so I'd like to welcome everyone to Grand Rounds. Of course, it's very good to be inside today. I know we all feel that with the cold. So, but it's my pleasure to introduce Dr. Vivek Prasad. Vivek is a PG2 resident in our program, and he's currently, we persuaded him to come over to the AOC to do his outpatient rotation with us over at University Hospital. But the case he's going to present today is not a case that he saw with us, but a case rather that he saw through LaRue Carter. It's a patient who has a behavioral presentation, unusual behavioral presentation of behavioral discontrol and emotion dysregulation. So Vivek did his medical school, his undergraduate and graduate education in a combined BS MD program through the State University of New York system. So that was CUNY and SUNY upstate. And he graduated in 2005 from that program. And then came to us here in Indianapolis to do his pediatrics internship, which he completed in 2007. And now he's undergoing his psychiatry training at IU. Vivek has strong interest in clinical and research neuropsychiatry. He's currently has a case presentation in pediatrics review of a child who had mercury poisoning, so a neuropsychiatric type case. And he was also involved in a Stanley Foundation grant looking at mechanisms of weight gain with atypical antipsychotics in schizophrenia populations. So he has research interests and also interests in medical writing. He was an editor of a medical student series, the McGill Journal of Medicine. So he was an editor of a series of articles that came out in that journal while he was still in medical school. So it's our pleasure to have Vivek with us today. And also for the question and answer part of the discussion, we will have some consultants and faculty who were associated with the case, including Dr. Blix and Dr. Bagar, Dr. Nurnberger would be available, Dr. Weaver, and several others. So please give Vivek a warm welcome to Grand Rounds.
Thanks for coming today. So today we'll talk about an interesting patient I'd seen at Carter. And this here is the outline of my talk, where I'll begin with the definition of behavioral phenotypes, move on to the case presentation itself, describe the types of aggression, and move on to the neurophysiology and pharmacology of aggression. I'll point out some key identifying history in labs, talk about some metabolic diseases and genetic syndromes that have psychiatric overtones, and the impact of the Human Genome Project on psychiatry and the upcoming DSM-5. Finish with some acknowledgments and references. So behavior. It's well understood that behavioral problems are more common in the intellectually impaired population than the general population. While health and illness aspects are clinically relevant, it is the aberrant behaviors that must be tolerated on a day-to-day basis. It is behavior that can destroy a family or lead to an admission to an institution, not IQ, nor enzymatic, nor cytogenetic status. So what is a behavioral phenotype? It's a characteristic pattern of motor, cognitive, linguistic, and social abnormalities, which is consistently associated with a biological disorder. The course of the syndrome is not stagnant in that it can vary with age. In some cases, this constitutes a psychiatric disorder. So again, if you consider the funnel, the environment, and the 4 streams, motor, social, linguistic, cognitive, any abnormalities can lead to a psychiatric illness. Here's the case of Tom, 44-year-old single Caucasian male, transferred from Logansport to Little Carter after having spent 6 years there. Chief complaints on admission included developmental disability, impulsive aggressive behaviors, labile experiences. Differential diagnoses include Axis 1, atypical psychotic condition, substance abuse or dependence, Axis 2, antisocial personality disorder, intermittent explosive disorder, mental retardation, pervasive developmental disorder, and Axis 3, cerebral palsy, traumatic brain injury, and the last 2, inherited metabolic diseases, genetic syndromes. For the purpose of this talk, I'll limit myself to these 2. His hospitalization at Logansport indicated poor impulse control, demanding behavior, verbal and physical aggression, several seclusions or restraints, medication adjustments, transfers to several different inpatient units, as well as a 90-day trial transfer to Richmond State before he finally made his way to Carter. His past psychiatric history: he had explosive behaviors since early childhood. His parents grew increasingly concerned, and the last straw was when he chased his younger brother around with a knife at age 9. Various inpatient and outpatient mental health care facilities are where he stayed, as his parents went from agency to agency trying to find help. He resided in a few group homes, but was found to be chaotic, persistently verbalizing suicidal ideation. Ultimately, he was committed to Logansport by a judge. His past medical history: allergies to chlorpromazine, flufenazine, history of cataracts, hyperlipidemia, and ringworms, tobacco use about a half pack per day in the past. His medications on admission included olanzapine, venlafaxine, enalapril, trazodone, zolpidem, valproex, Ativan, and benztropine PRNs. Social history was gathered from conversations with his father. They chose to send him to private school for added attention because of his developmental delay. He had a second-grade teacher who was involved in research at Purdue. That was on learning disabilities, and as such, he gained his best with her at that time. His father remembered numerous pink slips for fights in the playground. There was one instance where he impulsively slugged a girl for stepping on his toes while she was waiting in line for lunch. He graduated from high school through special ed classes. His father said that he was given a blank diploma, whereas his younger brother graduated the same year as valedictorian. No history of relationships with significant others. He came from a well-educated family: father a Lutheran pastor, mother a school teacher, 2 older sisters, one psychiatrist, the other a nurse, and one younger brother, a mechanical engineer. Denied any illicit drugs or use of alcohol. No legal history prior to the commitment. Denies any physical or sexual abuse. No work nor military experience. However, he did finish 2 to 3 months of goodwill job training, and soon after that he went to work at an equivalent of a CCC camp in southern Illinois. On a side note, a CCC is the Civilian Conservation Corps, an army of 3 million of Roosevelt's era who built the nation's bridges, roads, dams, monuments. And he has no family history of mental illness, alcohol, or substance abuse. His hospital course was fraught with aggression, numerous PRNs for anxiety and preoccupations of being jittery and dizzy. He assaulted several nurses as they attended to his needs, getting medications, etc. Assaulted 2 nurses and a peer while in med's line. Threw charts at his physician, punched his physician in the face, stormed out of the room when finding out that he was on one-to-one monitoring, became upset upon parents having left after a visit, and assaulted a nurse. I think you're really avoiding the issue. The real issue is your bark. Your bark is worse than your bite. Unfortunately, in patients like Tom, this is not the case. To control such aggression, we have to first understand it. So let's move on to types of aggression. Animal studies have shown there to be two types, predatory and affective. Predatory aggression is associated with little physiological arousal and offensive behaviors and is directed towards a positive reward, much like a cheetah chasing its prey. Affective aggression has a high level of arousal and defensive behaviors in response to a perceived negative outcome. In animals, this form has been associated with decreased serotonin activity, as well as increased noradrenergic and dopaminergic neurotransmission. Impulsive aggression, or the tendencies to act out in hostility and rage in response to stress or frustration, has been linked more closely to affective aggression. Again, there's evidence of decreased serotonin activity. There's still a lack of consensus on how to best classify aggression. So far, the only DSM-4 diagnosis is intermittent explosive disorder, and the criteria are vague and only fit a handful of patients. However, at the same time, a June 2006 NIH study revealed IED to be more common than once thought. They pointed out that aggressive tendencies and criteria are present before episodes of depression, anxiety, and substance abuse disorders, and may lead to these disorders as well. So they suggested that once aggression, anger is treated early on in a person's life, that those symptoms would not occur. Intermittent explosive disorder was found to happen in young men, almost 16% of the adults in the U.S., or 16 million, that's equivalent to 7.3%. Next, we'll move on to understand the neurophysiology of aggression. Numerous studies have elucidated the role of different serotonin receptor subtypes in modulating aggression. For example, novel anxiolytics such as buspirone act on the presynaptic receptors to create an antagonistic effect on the postsynaptic 1A receptors, thereby increasing the levels of serotonin. And other antidepressants are also displayed here. Tom's pertinent medications included hydroxyprogesterone, 10 milligrams daily, clozapine, 250 milligrams twice a day, helps control his anger. Valproex at 30 milligrams per kilogram dose of 3 grams per day at bedtime. Venlafaxine, 150 milligrams. Propranolol, 20 milligrams. Benztropine for jitteriness. PRNs, such as iprazidone, hydroxyzine, zolpidem, and trazodone for agitation and sleep. Next, we'll go on to talk about the medications used for treating aggression. First class are the mood stabilizers. Lithium has been useful in treating aggression in conduct disorder among adolescents, adults with borderline personality disorder, and in prisoners without any overt psychiatric diagnoses. Phenytoin, again in the prison population, carbamazepine, again in personality disorders. As far as valproex, there have been several randomized controlled trials that have shown its efficacy in treating agitation in the elderly, traumatic brain injury, PTSD, and a variety of other impulsive aggressive behaviors. Antipsychotics, again, even the standard and the atypical have been shown useful in controlling symptoms of borderline personality disorder and others. Clozapine, one study showed that clozapine markedly decreases the violent behaviors of patients and decreased the need for SNRs, and went on to suggest how a trial of clozapine should be done along with subjective or rather objective measures such as an overt aggression scale to monitor the patient's aggression while they're on clozapine. Trazodone, which affects serotonin 2 receptors, has been used widely for agitation and sedation. Beta blockers. Beta blockers at low doses tend to decrease frustration and anxiety, whereas at higher doses, with the pulses in the 60s, Propranolol and Pindolol has been used to control organic rage and aggressive symptoms. Serotonin receptor inhibitors, SSRIs. Again, there have been numerous studies pointing out their efficacy in treating aggressive behaviors. Hydroxyprogesterone has been used in controlling overt sexual behaviors, as well as some aggressive tendencies. So, despite all these medicines, not a single FDA drug has been approved for aggression. Despite the lack of approval, a number of current drugs are used for this purpose as before. The FDA, however, does recognize pathologic aggression to be an aspect of certain disorders, such as bipolar, schizophrenia, and has approved specific drugs for those conditions. There may also be a lack of market interest in that no pharmaceutical company has yet applied for approval. This may be due to several reasons, medical, legal, or even the research aspects, where animal models do not translate well to the humans. The same drug, i.e. methylphenidate, can show anti-aggressive effects in adolescents with ADHD, but precipitate aggressive responses in bipolar patients. In patients with panic attacks, yohimbine and lactate have been used to induce fear in the laboratory. However, no such model exists to study anger. MCPP is a promising compound found to induce anger responses in patients with generalized anxiety disorders, but not so much in other disorders. So along with the medications, Tom was placed on a behavioral plan. He worked on verbal and physical aggression with Dr. Pisano and individual therapy twice a week. He focused on learning coping skills, anger management, and relaxation techniques. He used the radio, walked, rested, played cards for relaxation. He even had off-unit privileges to walk with staff in fenced area for fresh air. He attended groups if he felt able to. So again, his hospital course, there were episodes when he felt very jittery, anxious, dizzy, depressed, habitually followed with verbal or physical assaults. Once he was observed to have dived onto the floor, stating he felt dizzy instead of collapsing straight down, thought to be malingering. This was until he fell and dislocated and fractured his right ring finger middle phalanx in November 2005. Overall, he did okay with medical management. He tended to do better. The behavioral plan was working for him, for the most part. This was until he fell again. This time, he shattered his tibia fibula, stayed in the hospital for a while, came back after having had surgery, and is able to bear weight. He was sent to the hospital on 2 separate occasions, one for electrolyte imbalances and another for respiratory failure. He was noted to be hypoxic, or rather to be wheezing, and found hypoxic on the floor at Carter. He was taken to Wishard, intubated. A pulmonary embolus was ruled out with a chest CT, and he did better for about 2 days. Just before he was sent back, he ended up having to be intubated again, with a PE being ruled out again. So eventually he was extubated, recovered, sent back on a soft mechanical diet, and he was sent back and he was tried on thickened fluids to prevent aspiration. Further workup, concerns of non-psychiatric etiologies raised by his worsening physical symptoms. He is evaluated by Dr. Hainline of Pediatric Metabolism Clinic. Metabolic labs included urine for genetic screen, plasma acylcarnitine profiles, carnitine levels, plasma amino acids, ammonia, lactate, aldolase, Chem17 including CK and uric acid. He was then diagnosed to have a Sanfilippo-like syndrome. Sanfilippo syndrome is caused by a deficiency or defect in the gene coding for NSGSH, or N-sulfoglucosamine sulfohydroxylase, which is located on the chromosome 17. Again, Sanfilippo syndrome is an autosomal recessive trait. It's a mucopolysaccharidosis, MPS, 3A disease, which is a lysosomal storage disorder where there's a defect in the key enzyme that degrades heparan sulfate. and as such it accumulates mostly in the lysozymes of the central nervous system, where it causes and results in tissue damage. This attributes to a steady degenerative course of this illness. Ben's dream. Ben's dream. Ben was a kid born with Sanfilippo syndrome. His parents started this organization, which is now the Sanfilippo Foundation, to raise awareness and fund research towards its cure. Take a look at his face and remember his thick eyebrows. Come into key here. So these are the medical and psychiatric features of Sanfilippo syndrome. Patients often have coarse, thick facial features, prominent dark eyebrows, vision impairment. I said earlier that Tom had bilateral cataract surgeries, gait disturbances. Tom fell numerous times, fractured several bones, progressive stiffness, severe diarrhea or constipation, severe hearing loss, speech disturbances. Dr. Blix had noted that he had a loud, unmodulating voice, which was very threatening and probably served him well. At the same time, it might have been due to his severe hearing loss and maybe a result of speech disturbances. As far as the psychiatric conditions, he had mild mental retardation at his last IQ testing of 64. Again, the aggressive behavioral tendencies, the physical aggression, all fit that well. He was noted to have a disorder, Sanfilippo-like syndrome, because the current tests that test for this syndrome did not show to be positive. Yet, Dr. Hainline might be able to explain further if he's here, but yet they suspected it as it was faintly positive. His March 2005 findings of his MRI showed ventriculomegaly with thinning of the corpus callosum, suggesting hydrocephalus as the cause of the ventriculomegaly. In a literature review, I found this one article which studied MRIs of patients with MPS, and they noted these patients to have a progressive degenerative course of the cerebrum and the corpus callosum, correlating with their neurologic findings. This is my chart review of consults at Carter. Carter has consulted about 75 patients through IU for their metabolic and suspected genetic conditions in the past 10 years. Main reasons for consults in the chart reviews included dysmorphic features such as frontal bossing, microcephaly, low-set ears, skeletal abnormalities, scoliosis, history of developmental delay learning disabilities, behavioral issues of inward or outward aggression, such as suicidal tendencies, overdosing, or outward aggression. What are some key histories to ask in such patients that you're suspecting to have a genetic or metabolic syndrome? Consanguinity is always important, as it can increase the chances of having an autosomal recessive trait. Learning disabilities, developmental delays, special diets or intolerance. So in cases of patients with urea cycle defects, one is the ornithine transcarboxylase deficiency, or OTCD. They have protein intolerance, and it's noted that children who have this disorder, OTCD, are often picky in that they take their cheese off their pizza before they eat it. So asking about these things, if you're really suspecting, might lead to a diagnosis of a disorder like OTCD, which would have otherwise led to the patient being institutionalized for schizophrenia. History of spontaneous abortions or infertility, sudden infant deaths as well. So what are some metabolism labs that were ordered? A quantitative plasma amino acid analysis, urine organic acid analysis, blood ammonia testing. The cost effectiveness of screening for these disorders is yet to be done. These are fairly expensive labs. I think it costs about $600 to get a CT on a patient. And in cases like the blood ammonia test, they have to be done rapidly, placed on ice, sent to the laboratory for evaluation, or else they may lead to false elevations. As such, these patients are most likely to be referred to a metabolic specialist for consultation. So let's talk about psychiatric symptoms of inherited metabolic disease. Due to our ability to recognize and treat these disorders better, it has led to a presence of an older patient population, much like that in Tom's case. As such, it's better to gain a better understanding of the psychiatric symptoms associated with them to allow them to plan their life out accordingly, to live a better quality of life, as well as informing the family of the risks of having this disorder within the family itself. Neuropsychiatric symptoms are the commonly associated symptoms of these disorders, and they most always culminate in the final pathway of CNS dysfunction, delirium, and coma. Phenylketonuria. This is one of the best examples of the advances made in treating metabolic conditions. This is a syndrome associated with mental retardation, but is now treatable with dietary modification, where if untreated, the accumulation of phenylalanine and toxic metabolites inevitably results in mental retardation with psychiatric symptoms. So as long as the patients stay on a phenylalanine-free diet, they're able to live a moderately well-off life. Early treated PKU adults have increased incidence of depressed mood and a variety of anxiety symptoms. Agoraphobia has been identified as a common symptom in patients off their diet. Even transient increases in serum phenylalanine levels can lead to transient cognitive deficits. The authors here have even suggested that IQ testing be used to monitor dietary control of patients, as it correlates very well with that. Homocystinuria, due to a deficiency of the enzyme cystione beta synthase. Medical symptoms include developmental delay, scoliosis, occasional seizures, CNS infarcts, hypercoagulable states, fatty liver, characteristic skeletal changes such as long limbs and connective tissue disorders, abnormalities. Psychiatric symptoms are depression, behavioral disorders, OCD, and personality disorders. And one study found a 51% comorbidity prevalence of these among homocystinuria patients. Schizophrenia has also been diagnosed in untreated patients. And the actual diagnosis is by elevated plasma homocysteine levels, as well as a urine test for disulfides. Acute intermittent porphyria is another metabolic condition, a disorder of heme biosynthesis resulting in intermittent attacks due to porphyrin elevations. Psychiatric manifestations include anxiety, depression, psychosis, and altered mental status. AIP may be mistaken for schizophrenia when psychiatric symptoms are the main presenting symptoms without any neurological findings. There's a high frequency of histrionic traits present in many patients before their initial attack. Many psychotropic medications may induce or exacerbate a porphyric attack, such as Haldol. This exacerbation may cause the patient to be labeled as treatment resistant and cause an admission to a long-term care psychiatric facility. An older study published in 1985 found that such facilities have higher rates of patients with acute intermittent porphyria. Metachromatic leukodystrophy is a lysosomal storage disease leading to cerebroside sulfate accumulation in the myelin of the CNS, as well as the kidney, gallbladder, and other visceral organs. It's associated with psychosis, delusions, auditory hallucinations. Finding in the second and third decades, that usually leads to a wrong diagnosis of schizophrenia. The ensuing rapid intellectual decline and dementia points to a diagnosis of a metabolic disorder. Only then. So again, Halsall et al. Studied unrelated patients with similar psychiatric presentations. They found progressive demyelination of the frontal lobe to be associated with deterioration of the mental status. These patients were all found to share the same aryl sulfatase A enzyme mutation. suggesting a correlation between a single gene mutation and a psychiatric phenotype. Now we come to genetics in psychiatry. This article by Philan et al. Studied whether one's understanding of genetic links to mental illness led to better health-seeking behaviors. Simply put, whether people understood the genetic causes of mental illnesses led them to go see a doctor. And they concluded that increasing an emphasis on genetic causes of mental illnesses may have several effects on patients' orientations to professional treatment. Genetic causes appear to play a major role in people seeking care, probably because of their view that genetically influenced disorders are more serious and chronic. At the same time, such attributes led to pessimism that the intervention will be effective. Next, I'll move on to talk about psychiatric disturbances in genetic and metabolic conditions. So this table here depicts various syndromes and their associated psychiatric symptoms. Fragile X has mood disorder, autistic features, schizotypal features, anxiety. Down syndrome, well known to cause dementia. Mucopolysaccharidosis, like Sanfilippo, also result in dementia. Velocardiofacial syndrome, schizophrenia. Tuberous sclerosis, autism and schizophrenia. Soto syndrome, autism and phobias. Sex aneuploidies, such as XYY, can lead to antisocial personality disorders. Their phenotype of having large muscular status as well as a low IQ may predispose them to that as well. It's good to understand how the environment plays a role in the pathology of these syndromes. Prader-Willi, mood disorders, OCD, paranoid psychosis, anxiety, and Duchenne muscular dystrophy with mood, schizotypal features, and anxiety. So we'll talk about Prader-Willi syndrome. It's usually caused by a deletion of the paternal 15q chromosomal region. The phenotype is seen by the narrow temple distance and the nasal bridge, the thin upper lip, downturned mouth, and of course the characteristic overweight. And there are psychiatric symptoms of impulsive aggression, psychosis, OCD, bipolar disorder, and PDD. Doctors Lithic and Bagar had sent Tom to get tested for this, and it turned out to be negative. Genetic tests used to diagnose Prader-Willi syndrome. I'll use this chart as an example to talk about the existing genetic tests. Most patients are sent to have a chromosome karyotype done for behavioral disorders, learning disabilities, just to rule out any major deletions of a chromosome or the existence of, say, XYY. And they're found to be useful. FISH, or fluorescence in situ hybridization, has been found to be useful in common typical deletions, such as microdeletions in VCFS. And newer tests exist, such as the subtelomeric FISH, which are helpful in detecting disorders when the initial chromosomal karyotype is found to be normal. These other tests are used to diagnose Prader-Willi syndrome, such as the DNA methylation test and polymorphism studies. So Fragile X. It's an expansion mutation of the Fragile X mental retardation gene on the X chromosome. Its characteristics include large ears, elongated face, and a prominent jaw. It can lead to mild developmental disability, mental retardation. Children and young adults with Fragile X syndrome often have behavioral difficulties such as tantrums, aggression, or self-injurious behavior. There's work going on here at IU itself where they're testing the efficacy of aripiprazole on patients with Fragile X. In a separate study, the researchers here followed the members of 4 generations of family affected with Fragile X. 3 of the 4 males with Fragile X chromosomes were found to have autistic behavior. An adult Fragile X male had a chronic schizoaffective disorder and mental retardation. In female relatives, the Fragile X carrier status was associated with more psychopathology, including schizoaffective and major affective disorders. VCFS, commonly seen as such, with a broad nasal bridge, malar hypoplasia, poor dentition due to a deletion of chromosome 22, and results in mild developmental disabilities. VCFS has a high prevalence of schizophrenia-like disorders among adolescents and young adults. Prevalence of psychosis is between 22 to 40%, according to a recent review of available studies. One of the genes in VCFS codes for catechol-O-methyltransferase, COMT. This enzyme metabolizes dopamine and other catecholamines. As such, there have been several studies that recently explored the link between schizophrenia, the dopamine hypothesis, and COMT metabolism. This comes to the role of genes and understanding it. So the goal of the Human Genome Project has been to find the chromosomal location of a diseased gene, to understand and identify that gene, to find the mutation that went wrong in the gene, and to understand the function of the gene and the mechanism of the disease to best correct it. Okay. So again, the Human Genome Project, the goal was to sequence all 3 billion base pairs in the human genome, identify all human genes. It was the largest and most important scientific project in the history of biology. The results showed that there are only about 35,000 human genes, and the function of about 7,000 genes has been known. Tools include 3 million DNA markers. More can be searched of these genes at the OMIM website. So, how does all of this play towards psychiatry's future, with the DSM-5 coming up in 2012? The research agenda published shows the growing realization that the existing categories are simply symptom clusters rather than cohesive descriptions of the underlying dysfunction. Hence the proposed new multi-axial system, including an axis surrounding the behavioral phenotype of an illness. So this is a table from that research agenda where this is the ideal that they're hoping to get to. Axis 1 is genotype, where they've identified the genes that cause the disease, identified the genes that protect against the disease, and the genes associated with therapeutic responses. Axis 2 is the neurobiological phenotype, where cognitive function, neuroimaging, emotional regulation would be placed. Axis 3 is the behavioral phenotype, all the things we just talked about. And Axis 4, environmental modifiers, such as the role that the environment would play, very similar to what Axis 4 is now, I suppose. And Axis 5 with therapeutic targets and response. I'd like to finish with acknowledgments. Kelly Kaneshiro is a tremendous librarian there. She helped me with a lot of finding references that are hard to find, a lot of Medline searches. Harold O. is Tom's father, who gave me all this background information about Tom. Jay Wenning at Carter Medical Records, who pulled out all these charts and put them back. Close Sarver for linking genetics patients with ours, and Stephanie Gernon for showing me this awesome book on the Atlas of Metabolic Diseases. Drs. Brian Hainline, Dr. Saidi for their knowledge on metabolic and genetic conditions. Dr. Nurnberger to tie this together to the genetics in psychiatry. And Dr. Blix, Pisano, Bagar, all who took care of Tom, who might be here to answer any questions you might have on management. And Dr. Detke, who walked through these slides with me earlier this week just to familiarize myself and references. Yeah. In looking back at how well he did before and after the medicines that he was started on, it seems that clozapine had the best effect in controlling his aggression. At the same time, it was good for him to know the cause of his problems, not that he's losing control, that he doesn't have any control, but that the control comes from within him, that there's a genetic cause for this. And that helps his family and himself cope better with it, knowing that.
So where does this patient go from here? What is the long-term prognosis and how you would treat this syndrome? And then any family members, what specific testing on?
Yeah, Dr. Hainline and his group met with the family and Tom and told them basically what was outlined earlier, that this is a serious condition, has a slow progressive course, and has turned for the worse recently with the falls, with the respiratory failure, is all leading towards that common pathway of CNS dysfunction, delirium, coma, where it is a slow deteriorating course. And Tom is actually one of the outliers. In all the literature I saw that there wasn't any patient who was as old as Tom. So I'm thinking now would be to get him to do the best he can and out of the institutional setting. Dr. Wicks, do you have anything to add?
Yeah, I was just going to add what he's doing now.
Uh-huh.
You're right, you mentioned that.
We communicated earlier this week just a little bit about one of my favorite pictures of Tom this past week. He now has a job in the hospital. He is functioning. His medications are Effexor. We have him up to 225 milligrams for his depression. The Depakote ER, a lot of this has just been, tweaked mostly, is at 3,000. It had gone down, but we have put it on just a twice-a-day regimen. And those are the major things that we are using. But this man now has a job in the hospital. He works an hour a day. He earns money. And my picture of him was him standing in the hallway with a mop, with his work gloves on, and that he was able to smile at me and joke that I had promised him, he was saying, I had promised him supposedly he was supposed to buy me a steak dinner with all the money that he was about to earn. And he was laughing and enjoying himself. And his pride level, I think, had gone way up from where it was when I first knew him, feeling like he was a total victim. And I remember when he came back from a discussion with Dr. Hainline, and he was saying, Dr. Hainline says I don't have a psychiatric disorder. I have a disorder that's something else. And I said, Dr. Hainline is correct. And it has affected these parts of your emotions, and that's what we're trying to help you with. And that did, I think your response to that question, Dr. Prasad, was excellent, because it really does say something about that his knowledge of what's wrong with him. So he is actually we're working on a group home placement for him at this point. Medically, he's actually stable. He does have difficulty with swallowing. He does use thicket in his liquids. He will have a downward course. We know that. We don't talk about that. We talk about what can you do today. And Dr. Passano has worked with him enormously on his coping skills. And I think that has, and he always refers to that, he has a sense of humor. His IQ is actually about 75. He's more in the borderline range at this point. He's not as resistant to testing. And he was very resistant to being psychologically tested at one point in time. So it is not that he's not going to do well in the long run, but in the short run, I think it's a hope redefined is the way I like to kind of put these things, because it is not a long term. We're not predicting it. We know where the future lies long term. However, we have to look from day to day with this gentleman, and since I've known him, he's had 2 major metabolic problems that Dr. Prasad has presented. So that's all I wanted to say about where we are currently, because he looks actually pretty good right now.
Any consideration of enzyme replacement therapy in this patient? Enzyme deficiency.
That's a good question, because I'd asked for Dr. Hainline to come by and talk if he was free during the day for this, and I don't see him here. But he did start him on carnitine replacements, I think, and that's the usual route that he takes with patients with any metabolic condition that's going to be treated with carnitine. But I'm not too sure how well that would suffice.
I'm not aware of anything else. I don't know of any specific treatment for this particular condition. Some of these conditions you have particular treatment strategies that you can use right now. Others remain to be developed, and you end up doing non-specific treatment of the symptoms. I think that this falls in that latter category.
For purposes of anybody, if the video system is working at Carter, and I want to acknowledge that if it is, it's important to repeat the question, and I think it had to do with any kind of, I'm one of those Carter people who tends to sometimes not always hear things, enzyme replacement kinds of questions, and Dr. Nurnberger was saying at this point there is nothing specific for this disorder. Is that correct?
That's my understanding.
That's his understanding. So just for purposes, if anybody over there is listening.
In addition to the metabolic issues, the CT they had suggested possible hydrocephalus and with increasing gait disturbances was like a normal pressure hydrocephalus ruled out.
I'm not.
Okay, he has what has appeared on his CT is essentially that they're not. It's basically his hydrocephalus is stable. He looks like an old hydrocephalic patient on a CT, and he's not had any further evaluation for that. Neurology has not really felt a need to actually see him.
Yeah.
Is that correct?
Yeah, in some consults they said that it's best if he follows up with the PCP rather than us.
About the mentioned anger management therapy as a part of his treatment plan, and what techniques seem to be most helpful for this particular patient?
Yeah, I was trying to get in touch with all the people who are taking care of him. Is Dr. Pisano in the room? He worked closely with him, and he traded some points back and forth, and nothing comes to mind right now.
Just to talk mostly with this patient, and I think that it's important to understand patient to patient because they're all going to be different. And I think that's one of the points that we're talking about anger management in someone. And I think this gentleman becomes angry when he gets frustrated or if he feels like he's talked down to. His voice is loud and is not modulated, and that's one that he does. I still think that there's a bit of a bulbar component to some of his speech. His gait's actually not bad right now. I mean, he's not using his walker. He was relying on his wheelchair and so on and so forth. What he could do is he could intimidate with that loud voice. And sometimes what I've had trouble with is too many PRNs have been given to him. I actually discontinued some of those because they were very quick to give him those instead of his trying to deal with his discomfort inside. So the major thing he feels is going to be anxiety. And it's out of that he ends up flailing his arms, and that ends up with things going in different directions and so forth. So with Dr. Pisano, going back to the therapy issue, what he's worked with has been mostly how do you deal with that anxiety, and and he'll refer to the coping skills. So if, for an example, when I had a conversation with Tom earlier this week, it was something like a complaint about how he was spoken to in the dining room by the people behind the counter because they didn't have his ticket there. Okay? So he said, that made me mad. So I said, Tom, I said, do you think maybe they might be having a bad day? And he said, you may be right. Now that shows evidence he's had therapy. The fact that I could make one single, that's not, obviously I wasn't doing therapy at that point exactly, but he was reflecting back on what he had learned. And he said, so the things I could say are, you may be having a bad day. So it's like kind of like, and then he came up with some worse ones, which were things like, don't take it out on me. And I suggested to him that perhaps he might want to leave that last part out. So there are just some simple things that over and over and over again, Dr. Prasad has done a marvelous job with being patient with this man, and also limiting his contact to twice a week, not coming at every beck and call. Another thing that they had available to them at one of the hospitals, I believe it was Logansport, was that Tom had the feeling that he could ask for a psychologist, that he called a psychologist or whoever, to see him at any drop of the hat. He wanted to talk to somebody, and he would demand to talk to the person that day. We've had some of that. And, we just don't do that where he is at this point in time. So he has to kind of talk himself through it. He has to learn a little bit about how to do some isotonic exercises, just a few mild things to try to figure out how to cope with this inner tension that he feels. And actually a lot of that has worked, and we've decreased the PRN use, and the nursing staff has to not be quite so scared of him. And if they're going to be that scared of him, they have to move him to another unit. But he's really doing quite well where he is right at the present time. So.
I'll just comment that there are DNA tests available for a lot of these syndromes now, and apparently not for this particular patient, but for many patients that would have syndromes like this. And it's worth keeping in mind Dr. Weaver's clinic. David Weaver.
We do that.
Mm-hmm.
Could I ask a question?
Yeah.
Okay. One of the things we did change the diagnosis on him.
To sensible like?
We put trying to come up with a kind of disorder that would reflect more what he was, because he certainly wasn't psychotic. But I think we put him in a cognitive disorder type thing, a secondary NOS secondary to there's a category in the DSM-4R that has something to do with organic illnesses and causes, and then also a history of factitious illness. He did in fact do some things that were factitious, but not all of those were due to his gait disturbance. Some of those were deliberate kinds of things that he did in order to get attention if he wasn't getting it. So that's really about all I could come up with, either the NOS categories, but I did put it down a cognitive disorder, NOS, with mood problems secondary to the MPS Sanfilippo syndrome variant. And I was thinking if anybody had a better idea for categorization of a diagnosis in this gentleman.
I don't know. There are.
And then I also put personality change in Axis 2.
Organic mood disorder or.
Well, I put that down in Axis 2. That's in there too. So we did change that from the initial diagnosis from what he had when he came in.
Actually, I'm not sure that's Axis 2 or Axis 1. That's Axis 1.
That's happily on that. That can be flipped into that kind of thing. So we flip it to that, and so we have two actually those, and then it's borderline intellectual functioning as opposed to mental retardation.
The other thing I was curious about in the diagnostic issues, he has antisocial personality disorder listed there.
No.
That was the differential.
That is no longer part of the.
That slide was on the differential diagnoses for his presenting.
No, that's not. No,
right.
No. That's an absolute no.
That seems more consistent.
Okay. Thank you.
Okay. Thank you.
So that's kind of what I came up with, 310.1 and
medical illness.